So we'll talk about the coagulation status and the surgical patient. So what do we need to know? We'll review some of the indications for anticoagulation and why patients need anticoagulation. We'll review specific medications, talk about mechanisms of action, monitoring of anticoagulant activity, and availability of reversal of anticoagulation when it's necessary for elective or emergency surgery. We'll review some strategies for perioperative management of anticoagulation and understand the relationship between anticoagulation and the safety of neuraxial anesthesia. So if we look at the normal physiology of hemostasis, it's really a balancing act. It requires a balance of two processes working together. One is the generation of stable localized clot at a site of injury. That's by procoagulant activity. And inhibition of excessive, unregulated thrombus formation beyond the area where it's needed. And for this, we need the counter-regulatory activity. Failure of this balance will either lead to excess clinical bleeding or pathologic thrombosis formation, both which we need to avoid. Who are the participants in the coagulation process? Well, the platelets are very important. The vasculature, the inside of the vessels, plays a key role as well. And then there are the proteins that circulate. There are procoagulant system, there's an anticoagulant system, and there's a fibrinolytic system, meaning the breakdown of existing clot. Now, the platelets are the circulating agents that are responsible at the very first response to an injury. We call them the first responders. They are cells derived from bone marrow. Typical circulating lifespan of the platelet is about 8 days. And disorders of platelets include having too few, thrombocytopenia, too many, thrombocytosis, or inadequate function of platelets. What about the interior of the vessels, the endothelium? Under normal circumstance, it promotes smooth flow of blood so that oxygen can be delivered uninterrupted to the tissues. Therefore, it must repel the aggregating tendency of the platelets by maintaining a negatively charged surface, producing platelet inhibitors, including nitric oxide and prostacyclin, and degrading ADP, which is a potent aggregator of platelets by an ADP inhibitor. To further limit excess clot propagation, the endothelium produces something called tissue plasminogen activator, TPA, and this causes fibrinolysis. So when the endothelium is injured, this balance gets disrupted. And we can see over here that the intact endothelium with tissue factor exposed, circulating blood and platelets, and a nice smooth endothelium. Here we see that the endothelium has been injured or disrupted. And what occurs then is a binding of platelets to the collagen, tissue factor-dependent initiation of coagulation. And this is what we know as the extrinsic pathway, and we'll talk more about that in a moment. The propagation of the clot then occurs by recruitment of platelets to a growing thrombus, and then amplification of the coagulation cascade by the intrinsic pathway occurs, which causes the clot to grow and then finally to stabilize. Platelet interaction and fibrin deposition causes this final step in the pathway. So first exposure of adhesive molecules, and then the platelets and coagulation cascade step in and become activated. And what we see at the end is the formation of a stable clot. So what does the vasculature do in response to an injury? For one thing, it synthesizes von Willebrand factor, which participates with the platelets in primary hemostasis. It also synthesizes factor VIII. It produces tissue factors for secondary hemostasis, which you saw in the last slide. And it produces substances also that inhibit clot breakdown, fibrinolysis. So the circulating proteins are factors that circulate in an inactive form for the most part. When the coagulation cascade is activated, there are successive activation of these proteins from an inactive to active form. We have an intrinsic pathway, which is prolonged by use of heparin, and we measure it by measuring the PTT, partial thromboplastin time. We have an extrinsic pathway, which is affected by warfarin, reflected in the prothrombin time, or INR. And finally, both influence a common pathway where factor 10 is converted to 10A, prothrombin to thrombin, and fibrinogen finally cross-links to fibrin. So generation of a stable clot starts over here by exposure of endothelium factor with vascular injury. And these are all factors other than factor 8 that are synthesized in the liver. And again, all circulating in inactive form until this event occurs. The intrinsic pathway participates mostly via amplification of the process. So it doesn't initiate, but it reinforces the process. So where do these anticoagulants that we use act if we want to look at the pathway? If we consider enoxaparin, rivaroxaban, and apixaban, they are 10A inhibitors, so they inhibit the pathway at the common pathway. Dabigatran is a thrombin inhibitor, so it inhibits the formation of activated thrombin and subsequently of fibrinogen to fibrin. And warfarin inhibits the vitamin K dependent factors, so these are going to be 2, 7, 9, and 10. Warfarin is a poison of the vitamin K dependent factors. It causes prolongation of the prothrombin time. In part, it is reversible in its effect by administration of vitamin K or by plasma. Other causes of prolonged PTT include liver disease, vitamin K deficiency, disseminated intravascular coagulation, and the target-specific anticoagulants, which include Dabigatran, rivaroxaban, and apixaban. The INR.
Rachel, is
Yes.
your volume turned up all the way? Somebody in Ramon
Yes.
says that the volume. Abed, maybe you can try to turn up your volume on your laptop. I don't know how else to solve this. Yeah. All right. Thank you.
Okay. The INR is an international unit that allows standardization of values from different laboratories. And it's essentially the patient's prothrombin time divided by a reference prothrombin time. So it is unitless. Unfractionated heparin works by complexing with antithrombin, inhibiting antithrombin, in addition to a pentasaccharide sequence. And it converts antithrombin from a slow to a rapid inactivator of 2A thrombin, 10A, 9A, 11, and 12A. So it essentially, it sort of accelerates the inactivation. The advantages of heparin are we can monitor it easily both with a PTT or a activated clotting time, and it is reversible with protamine. Its limitations, though, are several. One is that it's really a weak inactivator of preformed fibrin clot. It's less effective in the presence of certain acute phase reactants. There are heparin-resistant states, and there are patients who develop what's called heparin-induced thrombocytopenia, which is an immunologic problem where platelet counts diminish after exposure to heparin, and patients actually become paradoxically hypercoagulable. So for this reason, that its use is falling out of favor in many institutions. So what about the oral antiplatelet agents? There's the COX-1 irreversible thromboxane inhibitor, which is aspirin. Then there are the thienopyridines, clopidogrel, prasugrel, ticlopidine, and the P2Y12 receptor antagonist, ticagrelor, otherwise known as Brilinta. And we'll talk a little bit about each of these. Clopidogrel has many indications, including post-MI, stroke, peripheral artery disease, and after coronary stents are placed. Many patients are on an obligate duration of Plavix treatment or one of its drug types. It is a thienopyridine. It's a prodrug, so it requires enzymatic conversion to active drug, and unfortunately there are a large number of patients who are non-responders and to Plavix, unfortunately. It has a very slow onset, which explains why a loading dose is used when patients are in the cath lab. There's a large list of drug interactions, so the drug is tricky, and one of the drugs that's notoriously a problem are the proton pump inhibitors, including omeprazole. There appears to be a rebound effect when Plavix is discontinued. About 8 days after stopping, patients' platelets may become actually hyperactive. So while it's important to stop it for enough time before a procedure, we also may get the patient in trouble if he's off of it too long. Platelet transfusion may not recover platelet function. There is a very interesting case report and information in the package insert about acute reversal under emergency circumstances by administration of IV methylprednisolone. For neuraxial block, it's recommended that we discontinue the drug for at least 7 days. For other surgery, the most important and the most published has been coronary bypass surgery. The American College of Cardiology now recommends 5 days off Plavix prior to CABG surgery, and the Society for Thoracic Surgery says 5 to 7 days prior to thoracic surgery. Prasugrel is the same class of drug with the same indications. It also is a prodrug, but it's very uncommon to find non-responding patients, so in certain ways it's a better drug. It has a faster onset than clopidogrel, very few drug interactions, but it's a higher bleeding risk in certain patients. Elderly and small patients have more problems with bleeding compared to Plavix. It may require as many as 9 days for platelet function to be restored after stopping, and it's been described that platelet concentrate can reverse the effect if we need to do that in an emergency. For neuraxial block, the European Society recommends 7 to 10 days off of prasugrel. At UCSF, we have a protocol of 9 days. We sort of split it in the middle. Ticlopidine, frequently used for peripheral vascular disease, same class. It's a reversible platelet aggregation inhibitor. Elimination half-life is relatively short, 7 hours. It does prolong bleeding time. Platelet transfusion may be effective in an emergency, but we recommend stopping this drug for 14 days prior to neuraxial block. Ticagrelor, Brilinta, is used after acute MI and in some cases after stenting. It's a different class. It's a P2Y12 receptor antagonist. It's metabolized by CYP3A4, so we have to be careful in patients who have liver disease. These folks may have prolonged effect of this drug. It's also a reversible aggregator. Some important drug interactions are present, so it's important to check when patients are on numerous drugs. It increases the presence of digoxin. The elimination half-life is 7 hours. Platelet transfusion has been described as effective when necessary. The European Society of Anesthesia and our UCSF guidelines both recommend that neuraxial block be delayed for at least 5 days after discontinuation. So now if we look at the vasculature as another limb of the coagulation process, we can look at some of the drugs used to treat the coagulation cascade there. One is DDAVP, Desmopressin. It's used to treat mild von Willebrand disease in patients having elective surgery. It has also been shown to decrease blood loss in patients who are uremic, so who have BUN levels above, say, 40 to 50. The dose we use is 0.3 micrograms per kilogram IV, given over about 20 to 30 minutes. And what this drug does is it releases factor VIII and von Willebrand factor from the endothelium, and this in turn improves the function of the platelets. And what we see are 2 to 4-fold increase in levels of both of these factors for a duration of about 6 to 8 hours. There are some cautions in using it. One is patients can get hypotension if we infuse it more rapidly than over 20 to 30 minutes. And it's also possible to produce hyponatremia particularly if we redose a patient after surgery. So it's important to avoid administration of large amount of hypotonic fluids. So what about the protein? Let's look at the anticoagulation system. And we'll look at injectable anticoagulants. There are the low molecular weight heparins, including dalteparin, which we don't use very often, and enoxaparin, which I think you call claxicin. Our brand name is Lovenox. Is used commonly. And then the other class is the glycosamine glycans, fondaparinux, usually for patients who have heparin allergy. So the indications for these medications, deep vein thrombus prophylaxis, and this is all these drugs can be used for this. Acute coronary syndrome is usually we see dalteparin used, and for pulmonary embolus, either prophylaxis or treatment, we see enoxaparin and fondaparinux. How do we monitor the activity of these drugs? Really, they're all 10A inhibitors, so we measure the anti-10A level. Other coagulation tests are not useful. In emergencies, in general, protamine is not very effective in reversing these. It may be partially effective with enoxaparin, but not with the others. So how do we manage patients who need neuraxial anesthesia? There's a minimum delay of 24 hours from the last dose of enoxaparin, and that's minimum. If our dose of enoxaparin is greater than 1 milligram per kilogram for injection, we actually recommend waiting a longer period of time, as about 1 in 3 or 4 of these patients will still have detectable anti-10A activity after a 24-hour period. We do not permit neuraxial technique in our institution if a BID or twice daily dosing technique is used postoperatively. And generally, we try to avoid enoxaparin and epidural catheters because humans tend to make errors when it comes to timing of things, and we just find that it's safer to separate these two processes. So more and more popular now are the target-specific oral anticoagulants, and these are used both for prophylactic purposes and for treatment of certain disorders. And their advantages are no need for monitoring of lab function, and patients don't have to follow any special diet and avoid foods that contain high levels of vitamin K. Two main classes are the direct thrombin inhibitors, and really there's just one on the market right now that we use, and that's Dabigatran. And then the 10A inhibitors, which have the letters XA in them at some point, and that's sort of a nice way of reminding people that it's a 10A inhibitor. Those include apixaban and rivaroxaban. So Dabigatran is a prodrug, so it undergoes conversion to the active drug, and its clearance in the body is primarily through the kidney. So we avoid it or dose adjust it in patients with renal insufficiency, and we avoid it entirely in patients with renal failure because it will accumulate. Its approved uses are for treatment of deep vein thrombus or pulmonary embolus and prophylaxis for atrial fibrillation if the patient does not have a mechanical valve. So how does Dabigatran work? It is a direct thrombin inhibitor. Its peak onset is about 1 to 3 hours. Its elimination half-life is 14 to 17 hours, depending on patient's renal function, among other things, and age. It's a twice daily dose. It should be dose adjusted for renal insufficiency, and it's monitored by the thrombin time if it's if it's available, or the ECT is what we also call the activated clotting time. And when we monitor it, if thrombin time test is available, it's useful. The problem with the PTT is it will be elevated in the setting of this drug, but it's difficult to interpret how much drug is in the body on the basis of the PTT, so it's not very helpful. The ACT may be more helpful than the PTT. Now, the INR usually is prolonged with this drug, but again, it's difficult to interpret how prolonged the INR should be in the setting of reversal of the drug. So we don't recommend that the PT be used to guide how anticoagulated the patient is with this drug. So if we look at how we recommend patients discontinue the drug prior to surgery, one thing we have to consider is the patient's renal function, as we mentioned, but also what procedure the patient's going to get and how much residual anticoagulation would be clinically acceptable. This table shows you two scenarios, one where mild to moderate residual anticoagulation would be acceptable, and the other column here is where residual anticoagulation would not be permissible. So over here on the right, examples would be craniotomies, would be neuraxial anesthesia, operating on the eye, sort of areas where a little bit of anticoagulation can cause big trouble. Over here, you may be talking about surgery where a little bit more bleeding would not likely be detrimental. So if a little bit of anticoagulation would be okay, 2 to 3 drug half-lives between the last dose and the planned surgery should be acceptable. Whereas if no residual anticoagulation would be acceptable, then we really should wait for 5 drug half-lives. So for patients down here getting Dabigatran with normal creatinine clearance who are having a craniotomy or neuraxial anesthesia, we say take the last dose day -3. If we have, on the other hand, somebody who's got low creatinine clearance, we would say last dose day -5. And we are tending to err on the side of longer time off of it in patients who are getting neuraxial anesthesia. Rivaroxaban and apixaban will kind of group together since their mechanisms are similar. They're both 10A inhibitors. They have similar peak onset. The elimination half-life is relatively similar, maybe a little shorter in apixaban. Apixaban has less renal activity, so it's a little more forgiving in patients with renal insufficiency. Unfortunately, both of them need anti-10A monitoring for assessment of anticoagulation. So it's not a test that we commonly use, so it is a little bit more difficult. Its approved uses are for deep vein thrombosis prophylaxis and treatment for venous thromboembolus and for prophylaxis against arterial thrombosis in patients with atrial fibrillation who do not have mechanical valves. And again, activity by laboratory testing. The monitoring we use, again, when needed, is 10A levels. And the PTT will increase, like with Pradaxa, but won't define supertherapeutic levels. The clotting time may be helpful. PT INR is usually prolonged, but it's not useful. So how do we reverse the effect of these target-specific oral anticoagulants? Reversal for elective surgery really requires time. For emergency surgery, it's very difficult. There have been several reports showing that cryoprecipitate is maybe somewhat effective, but it's still not entirely reversing the effect. Factor 7 is probably better, but what we're recommending, if it's available, are to use these prothrombin complex concentrates. One commercially available is called Kcentra, and it's essentially a pooled collection of several clotting factors altogether. There's another one called FIBA, and if you're really in a pinch, you could consider dialysis if a patient has been on Dabigatran. However, this won't be effective for the 10A inhibitors. So if we look at the other side of the coagulation cascade, and that is the fibrinolysis, that is the breakdown of formed clot, that process may become very ramped up and dysregulated during surgery, particularly when we're seeing patients have large areas of tissue operated upon. And fibrinolysis may actually be the underlying cause of profuse bleeding during surgery. We see it in patients more often who have liver disease or large raw surface areas being operated on, patients undergoing cardiopulmonary bypass, and just in cases where we have high anticipated blood loss. And what you see more commonly in certain types of surgery is the use of antifibrinolytic drugs. And these are commonly used to limit surgical blood loss during certain cases. Cardiopulmonary bypass surgery, this is almost standard. Complex spine fusion surgery, there's been a number of large studies sort of demonstrating the safety and the limitation of blood loss in that, for those particular patients. And in trauma, there's a very important study showing that the use of one of the antifibrinolytics is associated not only with less transfusion, but with fewer bad outcomes. The two main classes are the lysine analogs, and these are epsilon aminocaproic acid and tranexamic acid. And I've abbreviated them here for convenience. The other class is serine protease inhibitor, and there was really one drug called aprotenin. And aprotenin was became introduced during the 1990s, and it was really, there was a lot of enthusiasm about the drug at the time. It was superior in its efficacy in limiting blood loss than the lysine analogs. But after it was in use for several years, there were large studies done on the safety post-marketing, which showed that the use of aprotenin increased the risk of renal failure, heart attack, and death in patients. So it was actually removed from the market in the US after those findings. So really all we have now are the lysine analogs. And what do the lysine analogs do? They inhibit the binding site on plasminogen. So it prevents its conversion to plasmin. And what plasmin does is plasmin actually acts as to inhibit the conversion of fibrin to fibrin degradation products. So lack of plasmin prevents fibrinolysis. So tranexamic acid has been shown to be very important for use in trauma patients who have significant hemorrhage. It's a very large study on about 20,000 trauma patients who had significant blood loss showed a decreased rate of transfusion and death when tranexamic acid was used instead of placebo. And although there was a lot of concern in theory about increase in vaso-occlusive problems, including heart attacks and pulmonary embolus, there was no significant increase in the patients who received the drug. So at UCSF, we have protocols for our major spine surgery about use of antifibrinolytics. The epsilon aminocaproic acid is less expensive and we use it more frequently. We use a low dose regimen for most surgery, and that's a 5-gram load over the first hour and then at 1 gram per hour thereafter. A high dose regimen is twice that amount, 10-gram load over the first hour followed by 2 grams per hour. And in pediatric patients who really have a problem with fibrinolysis, we're using 75 milligrams per kilogram load over the first hour, followed by 0.15 milligram per kilo per hour. With tranexamic acid, we're using a standard dose of 10 milligrams per kilogram load and then 1 milligram per kilogram per hour. It's clear with both of these drugs that higher doses translate into more effective limitation of bleeding, but the impact on thrombosis with these higher doses is still unclear. So there are situations where we avoid antifibrinolytics just out of concern that thrombosis may be a problem, and those are in patients who have planned free flaps, vascular anastomoses, any kind of a hypercoagulable state. And that's going to include people with previous deep vein thrombosis or pulmonary embolus, and patients with coronary carotid stenosis or stents. For severe hemorrhage in the operating room, some people are reaching for activated factor 7. It's really an off-label use to use it that way in the operating room. It's approved in the United States only for very limited use, and those are for hemophiliacs or for people with acquired factor 7 deficiency who need prevention or treatment of bleeding. The off-label use, though, is being seen occasionally for very difficult bleeding cases. It's a very expensive drug. It's been shown to be effective and safe in non-cardiac surgery after a study of patients undergoing prostatectomy. It's not necessarily a cost-effective measure, but doses of 20 to 40 micrograms per kilo were effective in decreasing blood loss and did not translate into any increase in thrombotic complications. Now, in cardiac surgery, the story is a little bit different. Those patients have real problems with fibrinolysis, but there was a small study done in cardiac surgery, and it was stopped because of alarm over the increased risk of heart attack and death from excessive thrombosis with its use. So its use is really discouraged in cardiac surgery. So just to conclude here, it's probably useful to, because there are so many drugs out there, it's useful to group anticoagulants together in our mind by class. There are subtle differences, but it's easier to think of them that way. It's useful at your institution, and we found the same to be true for ours, to have protocols in place for the following things: for perioperative stopping the drug, recommendations on how to and when and how to stop the drugs, perioperative treatment protocols for fibrinolysis and for reversal of these drugs if need be. We also have to think about when we initiate these drugs again after surgery, and the timing of epidural, catheter, or neuraxial block placement, and then the subsequent manipulation or removal of the catheter. And the creation of protocols requires multi-specialty input. This means the anesthesiologists, the surgeons, the cardiologists, the internists, and the hematologists really all have to weigh in and agree on a protocol. Currently, there's very little national consensus on many of these practices we talked about today. So we've all had to kind of go and look through the literature and come up with a best guess on how to manage this. And this is just to show you what we have online at UCSF. We've tried to put together some kind of a protocol so that we all at least sort of act in a predictable manner. This is a list of anticoagulants that are commonly used for venous thromboembolism prophylaxis. This column shows the minimum time between the last dose and when a neuraxial shot or catheter can occur. So, for example, if we look at Lovenox daily, they are saying here 12 hours. For 5,000 unit heparin, BID, there's really no restriction at all. TID, we wait 4 hours. And for rivaroxaban used in prophylactic dose, we say 48 hours. The minimum time between the catheter removal and when the dose can be given is given over here in this column. Same thing on therapeutic doses, the same information. How long we should discontinue it, and how long we have to wait after removal of the catheter to start the drug again. And these are some resources to look at. The consensus statement from the Regional Anesthesia and Pain Medicine of 2010. Levy wrote a very interesting and helpful paper in anesthesiology in 2003 on the perioperative impact of these newer anticoagulants. And this is gives from the Food and Drug Administration is a website on some of these drugs and drug safety. And with that, I'm going to stop and take any questions people have.
Okay, please, if you have a question, just turn on your microphone and ask Dr. Eshima, I'm sure we have a lot of questions, and just to start the discussion and encourage people to have some questions, I'd like to go back to your slide, Rachel, about residual. What residual anticoagulation is acceptable after stopping the anticoagulants, and in what types of surgery? And it was a table, but at any rate, and you have mild to moderate residual anticoagulation acceptable, for instance, in an abdominal surgery or I suppose a hernia surgery or something like that. Yeah, keep going. There it is. To the right. To the right. Yeah, that one.
Yeah.
Okay. If you look, yeah, on the right hand two columns, 2 to 3 drug half-lives for mild to moderately acceptable anticoagulation, permissible anticoagulation, and none, for instance, in brain surgery and eye surgery, because 1 drop of blood in an eye surgery looks like a hemorrhage. My question is, have there been any studies on infections, post-operative infections in these surgeries, with mild to moderate in particular? I'm talking. If you have a hernia surgery, which I presume is a mild to moderate, and we have a little bit of anticoagulation, and you have a little bit of oozing of blood post-operatively, and is there a difference in infection, or has anybody studied that?
That's a great question. I don't know the answer.
Yeah.
Yeah, I don't know the answer.
Yeah. Post-operative bleeding. Post-operative bleeding, accumulation of even small amounts of blood can invite infection. So this is something.
Yeah, it's a great question. I don't know, and I don't even know the answer for aspirin. Because we've been operating on patients with that through aspirin for years.
Yeah.
And I don't know the answer there either. Yeah, it's a good question.
All right, everybody else. Question. I'm sure you have questions.
I will say this. Presumably, most patients on these drugs are on them for a fairly substantial reason, and they undergo this surgical process where all of this, which is sort of a procoagulant insult, and I'm not really sure if the amount of oozing, if people have stopped it for 3 drug half-lives is appreciably different. I suspect it is in some patients more than others, but I don't know. I think that the problem is you never know when you're going to be unlucky with this.
That's right.
It's a real problem.
That's right. Okay, what else? Other questions? Any questions? They don't have to be. Don't be afraid يا شباب، ما تتكسفوش يا شباب. محدش راح يضحك عليكم، بمزح عليكم علشان تسأل سؤال غبي. مفيش حاجة اسمها، اسمع، مفيش حاجة اسمها سؤال غبي، في حاجة اسمها خطأ غبي لأنك ما سألتش السؤال. صح؟ Please.
I have a question for people. What would you currently do with venous thromboembolism prophylaxis? When is it usually started is it in the operating room, or does it start it the day after surgery or the night after surgery, or when does it usually, is it initiated?
Who wants to answer? Who wants to take the answer to this question? In Palestine, thromboembolism prophylaxis. Who wants to talk about this? Turn off your microphone. Turn on your microphone and talk. Okay, Diya. Dean, you turned on your microphone.
Yes. Actually, I have a question, but
speak up. No. You have to, you have to turn on your turn up your volume.
Hello.
Hello.
Hey.
Yeah.
I have maybe also maybe I will answer that question for Dr. Rachel.
Okay.
Actually, most of the surgeries, if we are going to do like prophylaxis for this DVT or pulmonary embolism, we are starting to use Enoxaparin, but most of the time it's like 12 hours after the surgery.
Yeah. So, you know, we're
also it's sub-Q. We are using like prophylactic dose sub-Q. I think it's 40 milligram per kg.
40 milligrams daily.
It's 40 milligram only.
Yeah.
I have a question. You have mentioned anesthesia.
Is that on your side, Rachel?
Hello.
I don't know. I don't think so.
Okay.
حبيبي الله يخليك.
قاعد في القهوة يسكر معلش. Okay, ضياء, you have another question.
Yes. Dr. Rachel has mentioned that we have to wait for 24 hours if we're going to do Neuraxial.
مين اللي
that true?
القهوة رعد؟ أنت بتأرجل ولا شو؟
أكبر شيء معناها 3 إكس معناها.
Anyway, your question is, you mentioned that you have to stop anticoagulation 24 hours. Can you refer to what particular anticoagulant?
Enoxaparin.
Okay, low molecular weight heparin.
Yeah. Rachel has mentioned that we have to wait 24 hours if we need Neuraxial block.
بس مش يطلع مقاس البدله مش جاي يطلع فيها الخلفيه مش
dosing. So if we're using 1 milligram per kilo BID, we wait 24 hours before the last dose. We're using a prophylaxis dose, like half milligram per kilogram, 30 or 40 milligrams.
What is this noise? How much? Please turn. Whoever is on. Okay. Let me just take. Let me just take a guess. Okay. Okay, Rachel, can you talk again? I think.
Yeah.
I think I got it. Maybe not. This is hysterically funny. Well, I don't have a cafe here in my house, and so we have VIIA and yeah. Okay, go ahead, Rachel. I'm sorry.
Oh, I think the question was how long waiting is necessary after the last dose of enoxaparin, and we would say if patients are getting therapeutically anticoagulated, so with 1 milligram per kilogram twice daily, which is considered a standard therapeutic dosing regimen, we wait at least 24 hours after the last dose. In fact, we found that studies have shown, that looking at pharmacokinetics, that 24 hours after the last dose of therapeutic Lobinox, 1 in 6 patients actually still is clinically anticoagulated. So even if we wait that 24 hours, 1 in 6 of our patients are going to be clinically anticoagulated in spite of that. So in some patients who are very concerned, we actually make the last dose 24 hours prior to the neuraxial block a smaller dose. We may have them get anywhere from 0.5 to 0.75 milligrams per kilogram. If patients are getting dosed for prophylactic purposes, then we would wait at least 12 hours after the last dose is administered.
In answer to Rachel's question, can everyone hear me okay? Somebody say yes or no. Rachel, can you hear me?
Yeah, I can hear, well, barely, yeah. It's like there's a party going on in here.
Oh, behind you?
Everywhere, all around me. It's in surround sound.
Yeah, surround sound. Can you just kind of look at them gratefully and ask them to like lower their voices a little bit and the noises? Just
No,
look at
I don't
them.
think.
Yeah. Listen. Use your charm. Use your charm. I just use my mean face and it works. But you can just please.
So, did I have another question?
Yeah, well, you have another question, and I think this is a very important question about thromboembolism prophylaxis perioperatively in Palestine. This is a big problem,
Yeah.
and that we have, and maybe some of the veterans like Dr. Rawand Ratrout can turn on her microphone and talk to us a little bit about this, because this is something that we have been debating with even IMEC 2000, whether or not we should have a mini workshop or a conference on thromboembolism prophylaxis in Palestine. They don't. Dr. Julia Morsh-Siddall, obstetric anesthesiologist from Britain, who was in Palestine at the end of March, or in March, actually went through a little bit of research looking at the Ministry of Health data on C-section mortality in Palestine. And she discovered that, correct me if I'm wrong, you guys, I don't have the lecture in front of me, but I think something to the effect of 30 or 35% of C-section mortalities in Palestine were caused by thromboembolism, which is something you don't see a lot in low-income countries, developing countries. Well, there's a good reason. Rawand, I see you turned on your microphone. Do you wanna comment on that, please?
Hi everybody, how are you? I didn't see any prophylactic measures before the perioperatively here at least in Al-Maqasid, but what I heard from Dr. Julia, you said, because I didn't meet her, that she advised us to put the prophylactic pressure on the legs of the patients in the cesarean sections. I asked them to do that as she advised us before in her lecture, I mean the obstetrician, but they said that it's not, you have to do that. Once I asked them to do that, they said, it's your job, you have to do that, and we don't have these pressure, how do you call them? Socks or?
Sequential compression devices.
Yeah, we don't have them. Also I think I see maybe in the general surgery, we put these pressures, and so if I'm wrong, I don't know. I think Dr. Abdullah used them sometimes in the general surgery, in the sleep gastric.
Abdullah Hawari?
I think so, yeah. If I'm not, but
very...
generally we don't use them. We don't use any here in Al-Maqasid. I didn't see using any prophylactic measures.
Yeah. I was surprised that they didn't use them in the bariatric patients.
Yeah, in the sleep. Maybe I'm wrong. Maybe I saw them in Hadassah, not in Al-Maqasid, because we used to to use them in liver surgery, hepatic surgery, I mean, sleeve gastrectomy, but
Yes.
maybe I'm wrong here. We don't see them here in Al-Maqasid. And if I'm not wrong, I heard that this week we had a patient from I don't know from where, maybe from Nablus, who was transferred to Al-Maqasid, 20 years old patient after cesarean, who died because of massive pulmonary embolism. Not this week, I think. But here I don't think so that we have any in Palestine prophylactic measures other than Clexane post-operatively, maybe 12 hours or what the surgeon decides. When I mean the timing of the initiation of prophylactic anticoagulation post-operatively, but before they give Clexane, I think that they give, because when we ask them if we want to give spinal, they say that, yeah, we stopped it 12 hours before or something like that, if it is prophylactic. But any other measures, I don't think so, that I see in Al-Maqasid.
Clexane, by the way, Clexane is, in case you didn't catch it, Rachel, Clexane is an enoxaparin.
I'm sorry?
Clexane is enoxaparin.
Yeah.
Molecular heparin. This is a huge problem in Palestine. Huge. You know, ladies and gentlemen, I had in 2003, I had a anterior cervical fusion, anterior cervical discectomy and fusion. And they used everything on me, of course, because in the United States, they used not only the stockings, which is like the women's stockings, you know, sharabat. No, they used the sequential air compression device on me. They put me on subcutaneous heparin after the surgery. And yet, 3 days after the surgery, I was at home and I had swelling of my right foot, and it was very painful. And I went and I had a Doppler ultrasound, and I had a small popliteal clot in my right popliteal vein. And then they put me on Clexane, and they eventually I was on warfarin for 3 months. So it's to see to see that we have 35% mortality from C-sections only from deep venous thrombosis and pulmonary embolism is just disastrous. This shouldn't be happening. And I think this is one of the most important public health issues to be addressed in Palestine. The Ministry of Health is interested in organizing a conference like that, and I think IMET 2000 is keen on organizing a conference for that, where we would maybe bring 1 or 2 experts on the topic. So,
Yeah.
Dr. Diya Al-Jabari from Hebron has a question about rebound effect of clopidogrel. And
okay.
Rachel, can you just linguistically define the word rebound effect first before you
I'll try my best.
Uh,
So rebound is sort of the process where when you stop something and you and something returns to its previous state. Rebound is when it overshoots and goes and it overcorrects from where it would have started initially. So if your platelets,
can I throw in just an example?
Sure.
Can I throw in an example, because I know I kind of You're kind of blindsided a little bit by this. You know, you guys, Shabab, when you, if you have a stuffy nose, you have an obstructed nose because you have vascular swelling in your nose, and you put neosynephrine, okay, phenylephrine, in your nose, immediately it causes vasoconstriction, and you're breathing fine. And about 1 to 2 hours later, your stuffy nose is not only back, it's worse because there is more vasodilation after the effect of the phenylephrine has worn off, is gone from your nose. This is called rebound vasodilatation. So, so you start with one problem, you treat it with a short-acting drug, and once the effect of the drug is gone, the problem is worse. That's called rebound. يعني بتقفز أعلى وأبعد مما كانت بتقفز في الأصل. Okay. Okay. Go ahead. Sorry. Just it's not a hard. It's a hard vocabulary word too.
Yeah.
Okay. Go ahead. So yeah. So clopidogrel.
So commenting on the rebound effect, the idea is that you want to stop the drug, whether it's clopidogrel, which seems to have a rebound effect after it's been stopped for about 9 to 10 days, or aspirin, which also seems to show a rebound. There's a rebound process. We talked a little bit about it last week in the lecture. When patients are off aspirin for more than 8 days, in that period of time, the platelets also go through a period of being hyper adhesive. Whether that's some upregulation of some of the receptors or not, it's hard to say. But in any case, it's an observation that we've seen and made over time. So I think the important lesson is to stop these drugs not for as long as possible, but for the right amount of time. And for aspirin, we're tending to stop it for about 5 days, no more than 5 days, maybe 5. But if we're stopping aspirin for 10 days, you're getting a patient to the operating room on a day when his or her platelets are really adhesive. So that's, at least in theory, going to put people at higher risk for venous thromboembolus and arterial thromboembolus as well.
Good. Okay. What other questions? We have some time. Yes. نعم. Who's asking?
Let me ask another question while people are thinking. Now, at your institution, and when a patient has an indication for anticoagulation, such as high-risk atrial fibrillation, who manages the anticoagulant preoperatively and postoperatively? Is it the surgeon or the cardiologist, or is it the anesthesiologist?
I think the anesthesiologist is the last one who manages these things. It is the surgeon with the cardiologist.
Really? Okay. It's just interesting because I wanted to comment that actually at UCSF, it's the anesthesiologists that take the lead in this. We manage all of the perioperative anticoagulation, including decisions on when and how to bridge patients who are high risk for arterial thrombosis, so patients with rheumatic heart disease and atrial fibrillation, for example, or people with mechanical heart valves. The anesthesiologists are actually taking the lead in managing all of the anticoagulation decisions along the time of surgery, because we were finding that the surgeons weren't doing it a very good job, and the cardiologists didn't really have a good understanding of what the surgery was going to entail. So it really fell into our hands to do it. We kind of do it we sort of lead the team. We involve the surgeon and the cardiologist, but we've really made the most of the decisions are made in our clinic about when and how to do this. So it's I think the important thing is not that it be one person, but just that there's a process that occurs where patients get the best practice. We've had bad things happen. For example, patients stopping their let's say they're Dabigatran, who are high risk for atrial, with high risk atrial fibrillation, and then for whatever reason the surgery gets postponed for a week, and they stay off of their anticoagulation, and they have strokes. We've seen that more often than we care to admit. So that was one of the driving factors that made us decide to just step in and manage things, because it was unacceptable what was happening to patients. So you know, somebody in the middle, somebody who's sort of in the middle of the process has to do it. The cardiologist is peripheral to the operative process, and the surgeon may be busy and peripheral to the medical issues. So it's a good opportunity for us as a specialty to really make a helpful impact on the patient's care.
Can I'd like to throw a few ideas here. Since we still have a fair number of young people attending, a couple of things. I've been talking, us at IMET 2000, the funding and organizing NGO, thanks to whose efforts and generosity we have all of this. We have all this program. They are always looking for ideas for education, because it's an education foundation. IMET means International Medical Education Trust. And so we believe in education as the main source, the foundation of changing healthcare habits and practices from traditional practices to best practices. And one of the things that jump to the eyes of anyone who comes to Palestine, there have been now 3 or 4 of us, Dr. Julia Morse-Siddall, Dr. Eshima, myself, I know Mustafa Khreshi, Hadil, for instance. Next week we're doing 2 lectures on the very basics on how to read research and how to evaluate research and how medical knowledge is created. Because and as this is just an I'm introducing this to let you know, well, what we need to know, what we need to do here is to identify the burden of disease from surgery, the burden of surgical disease. And one of the biggest burdens of surgical disease I see is thromboembolism, quite frankly. The best I've seen in Palestine, the best thromboembolism prophylaxis I've seen in Palestine so far has been putting ACE wrap. هاي الشغلة البني المطاطة اللي بحطوها حوالين الرجلين. Okay, ACE wrap around the legs, and that's it. Okay, and you may have a patient on a table for 10 hours or 12 hours, and all they have is ACE wrap, if they have ACE wrap. And it's very alarming that 30-35% of C-section mortalities, 1/3 of C-section mortalities come from thromboembolism. And I'd like to throw the idea ارمي البذرة وبعدين بعد يعني كم اسبوع هيك نحكي فيها. I'll throw the seed now is what I just said. I'll throw the seed now and maybe we can discuss it a little bit more in the near future to have a pan-Palestinian على مستوى فلسطين كلها thromboembolism task force. And thromboembolism, no question, is the main source of fatal thromboembolism is perioperative, and the result of being bedridden for a long time. Because if a patient is ambulatory and is walking around and he has atrial fibrillation, the cardiologist will take care of that. The cardiologist will put him on anticoagulants. The problem is the grandmother, Hajja Teta, who is bedridden, and next thing you know, she dies of a massive pulmonary embolism. So yeah, it's very important, and I think that next week we are doing research, right, Rachel?
Yeah, we're going to do some talks on evaluating the literature.
Friday and Saturday of next week. Basics of research. So we've done that. And we will do next Friday and Saturday, inshallah, God willing, and the creek don't rise. That's what inshallah means. In Arabic, yeah, if God willing, it literally means God willing, but yeah, you can say God willing, or if the God willing and the creek don't rise. The 15th, 1/5, and the 16th, 1/6 of May. So 15/5 and 16/5. Dr. Rachel, with I'm sure some translating effort on my side, we will introduce the very basics of just essentially how medical knowledge is created. Somebody doesn't just sit down and write a textbook. You know, this textbook has to be based on research, and the research is published in scientific journals, which are reviewed by other experts. And so it's so I think it's going to be very important, and I want you to start thinking about, while you're listening to these lectures, about what problems we have in Palestine, and if people are interested then in having a comprehensive scientific methodology, including statistics, including study design, and so forth, in the next few months or years, I think that would be very important, because Palestine has a lot of problems that need to be studied. And you know, you cannot depend on studies in the journals sometimes, because the studies in the journals, you see a study in the British Journal of Anesthesia, and the study was done in a Swedish hospital in Sweden. Well, that pertains to people in Sweden. One of the biggest problems that we have, and this is one of my biggest problems, is that 90% of the medical literature in the world pertains to the Western advanced industrialized world, and nobody pays attention to what's happening in other countries. So next 515 and 516 is going to be research methodology, study design, statistics. Statistics are only part of this. It's not just a question of, somebody was saying the other day, I'm interested in biostatistics. Well, yeah, statistics is how you interpret the study that's been made. But you also have to apply the statistics to something that actually benefits
Mhm.
people.
Yeah, I think you have to ask the right questions. You have to ask the right questions
That's correct. You have
first.
to ask the right question,
Yeah.
because if you ask the wrong question,
Statistics to try to support the validity of your findings, but I think that you got to first. It starts with the question,
that's
and
correct.
you find the right question by, like you said, identifying where your problems are. Where are we falling short? Where do we need to go? How do we need to do better? And there are an awful lot of studies done that are kind of cool and interesting, but they don't address anything that's very clinically relevant. And it's a shame that there's so much kind of effort and expertise that goes into things that I'm not sure ever are going to matter.
Exactly. Okay. Any other questions about? I have to review some of these. Okay, Dr. Mustafa Qureshi, who joined us, he says he's so happy that we have, and his feelings can't be described because of the attendees. Well, good work, Mustafa. You know, a lot of this is you. Okay, Hadil says, please, could you please tell us about using tranexamic acid in postpartum hemorrhage? Is it recommended? Thanks.
Interesting. I don't know about postpartum hemorrhage. I actually, that's a very good question. I would have to research that. I don't know. Yeah, I think that that's a very good question, and I can certainly look into it and get back to him.
That,
Yeah,
and
I don't know.
you know, the other thing, okay, tranexamic acid and postpartum hemorrhage. Let me, you know what I'm going to do, Hadil? Okay, Hadil, you don't have a microphone, I know. But, okay, Hadil, I'm just writing down, that's why I'm speaking slow.